So greetings from beautiful and very hot Greece. I hope you're doing well. In the next few minutes, I'm going to talk to you about a case of a late onset prosthetic valve endocarditis with cerebral thromboembolic episodes and aseptic meningitis that came to our hospital. Now, as we know, infective endocarditis, prosthetic valve infective endocarditis, we can separate it in early and late, with the cutoff being the first 2 months or after the first 12 months of the surgery. Now, embolic events are very frequent and life-threatening complications of infective endocarditis, presenting in 20 to 50% of the patients. And specifically stroke, it's a severe complication and is associated with increased morbidity and mortality rates. Embolic complications are a frequent reason for persistent fever and local infection, since the risk of embolization increases with vegetation size. And we know that in prosthetic valve endocarditis, vegetations tend to be larger than in native valve endocarditis. Silent cerebral embolisms occur in up to 60% of the cases, with neurologic symptoms occurring in 15 to 30% of the patients. So we have to always keep in mind that the patient might have an embolic event that we have not found because he didn't develop any symptoms. Now, our patient is a 57-year-old man with a history of coronary artery bypass graft surgery with mitral valve replacement done in March 2023. And we see the patient just a year after, in late March 2024, because of fever up to 40 degrees Celsius with rigors that started 12 hours before the presentation. Now, the patient did not mention any other symptoms, and during our clinical examination, we only found a left hand paresis. The initial laboratory examination was normal, with normal white blood cell count, negative CRP values. The chest X-ray was normal and no pyuria was noted. So we have a patient with a neurological sign and fever. So we're thinking, what is it? An infection and a stroke? Is it a CNS infection? Is it infective endocarditis? So there is a saying in philosophy by William of Ockham that says that always the best explanation is the simplest one. And I think it's really important to keep that in mind in medicine, that always we have to try to explain a situation with the simplest way, the simplest diagnosis. So it has to be something that can explain everything. So we first thought about infective endocarditis. We performed a transthoracic echocardiogram that was normal, and then a brain CT that showed an infarct in the right frontal subcortical white matter. So there it is, our patient has a stroke. But where is the fever from? So we admitted the patient in the internal medicine clinic to investigate the origin of the fever and to monitor the neurological symptoms. So we performed a lumbar puncture that was significant with 210 cells, with 60% being neutrophils and elevated protein. So our patient has a CNS infection and a stroke. It didn't add up. However, we started, after taking 2 sets of blood cultures, we started the patient with ceftriaxone, vancomycin, and amikacin to cover both the scenarios of a CNS infection and infective endocarditis. Later, the blood cultures came out positive for an MSSA, so we came closer to the diagnosis of infective endocarditis. Why? Because now we had 1 major criteria and 3 minor criteria of the Duke's criteria. Why? Because we had 2 sets of blood cultures that were positive for a bacteria that is known to cause infective endocarditis. And we had 3 minor. We had fever over 38 degrees Celsius. We have arterial embolism. We had a stroke, and we have a predisposing condition. Our patient had a prosthetic mitral valve. Then we performed the brain MRI that showed 3 different infarcts. And at day 5, we performed the transesophageal echocardiogram that showed a large vegetation of 1.2 centimeters in the mitral valve with a possible abscess. So we changed the antibiotic coverage to vancomycin, rifampin, and gentamicin according to the guidelines. Then we performed a whole body CT that showed splenic and renal infarcts. However, our patient's kidney function were normal. Then the patient transferred to the cardiology department in order to have a more close monitoring. The doctors there took another set of blood cultures that came out positive for the same MSSA. The patient continued to have high fever. So there were many indications for him to perform early surgery, because the basic indications for early surgery in the case of a prosthetic valve endocarditis are if the patient has develops heart failure because usually of the severe dysfunction of the valve, if he has persistent bacteremia after 5 to 7 days of appropriate antibiotic treatment that our patient had, if he has evidence of heart block or cardiac abscess, if he has fungal or highly resistant bacterial PVE, or in the first 72 hours after a cerebral thromboembolic episode, or if he has large and highly mobile vegetations over 10 millimeters in the mitral valve that our patient had. So our patient had at least 3 indications for early surgery. So he transferred to the cardiac surgery department. He got operated and he's now alive and well. So what is the point of this poster? The point of this poster presentation is that you have to know that most embolic events in infective endocarditis occur before admission. So they make the presentation of the case variable. It can easily confuse us. So in every patient that has a predisposing condition for infective endocarditis, we have to keep in mind that it might be the case. Also, we established that the transthoracic echocardiogram is not always positive as a diagnostic tool in infective endocarditis. Our patient had a completely normal transthoracic echocardiogram, and then in the transesophageal echocardiogram, we saw a large vegetation. So if we believe that it's infective endocarditis, we have to perform at least transesophageal echocardiogram before we dismiss the diagnosis. In the latest guidelines of the European Society of Cardiology, they have put as a diagnostic tool the cardiac CT, which is more sensitive to diagnose the cardiac abscess, and the PET-CT with fluorodeoxyglucose as an alternative if there is a contraindication for transesophageal, or if we do not have the ability to perform a transesophageal echocardiogram. Thank you very much. That was my presentation.